Welcome back to the last lecture of the analysis of the facial beauty in 2021. We will talk about the smile aesthetics as the last topic of this class. The analysis of the smile is an important part of facial aesthetic evaluation. When looking at or communicating with an individual, the observer's eye flit between the individual's eye and mouth, which are the most expressive region of the face. In fact, in considering features that are most influential to pleasing facial aesthetics, the appearance of smile has been ranked second only to the eyes. In fact, it is very interesting that most of the described guidelines in orthodontics and prosthodontics relating to smile and dentogingival aesthetics are derived from the literature of dental prosthetics. There are two types of smiles that has been described in the scientific literature. One is the paused smile. This is a voluntary smile not linked with emotion. For example, asking an individual to smile when taking a photograph. It is fairly reproducible. It may also be termed a non-Duchenne smile, a simulated smile, or even a false smile. The term social smile was used by the English poet Thomas Gray. The another is the spontaneous smile. This is an involuntary smile often linked with the joyous emotion. It involves larger facial movements, including squinting of the eyes, hence the term smiling with the eyes, and flaring of the nostrils and maximum elevation of the lips. It may also be termed as a Duchenne smile or true smile. The main distinction between the paused and spontaneous smile is the involvement of the orbicularis oculi or eye muscle in the latter. In the mechanism of the human facial expressions, the pioneering French neuropsychologist Guillaume Benjamin Armand Duchenne proposed that this involvement would distinguish the smile of enjoyment from a simulated smile. For example, 5-month-old infants show the eye muscle smile when the mother approaches, but a smile without the eye muscle when approached by a stranger. Moreover, when a spontaneous smile is shown in adults, the pattern of the brain activity found with genuine enjoyment occurs, but the brain activity pattern is not found when the paused smile alone is shown. To pay tribute to the Duchenne for this discovery, Paul Ekman proposed the spontaneous smile, which involves the action of both of zygomaticus major and orbicularis oculi muscles, be termed the Duchenne smile. The renowned English naturalist Charles Darwin, in The Expression of the Emotions in Man and Animal, correctly emphasized that the clue to recognizing the true smile of enjoyment, the spontaneous or Duchenne smile, is the lowering of the lateral portion of the eyebrow. This is a subtle change, but together with the lowering of the superior palpebral fold, it is a reliable sign that the outer fibers of orbicularis oculi have been contracted and enjoyment is occurring. Ekman has demonstrated that the crow's feet wrinkles and the bagging of the skin below the eye can be produced by a strong action of the zygomaticus major muscle alone, without any contraction of the orbicularis oculi. Now we are talking about the generation of a smile. Two stages of smile formation have been described. In the stage 1, the levator muscles contract, thereby elevating upper lip until resistance is met from the cheek fat present in the nasolabial folds. Then, the stage 2 of the generation of smile involves further elevation of the upper lip against the resistance of the nasolabial folds and also elevation of the nasolabial folds themselves. Various muscle groups are involved in this movement, including the levator labii superioris muscles and the zygomaticus major and the superior fibers of the buccinator muscle. The orbicularis oculi muscles may also participate in the effort to elevate the upper lip against the nasolabial fold, which produce the characteristic squinting of the eye that accompanies the spontaneous smile. It is notable that Darwin made an interesting observation, noting that when a man closely shuts one eye, he cannot avoid retracting the upper lip on the same side. Ekman has pointed out that the elevation of the outer corner of the upper lips that occurs when the ipsilateral eye is firmly closed is due to the action of the orbicularis oculi alone, which stretches the skin and causes this change in the upper lip, and not the activation of another muscle in the midface. Stage 1 is similar to the post-non-Duchenne smile, and stage 2 is the spontaneous Duchenne smile. Now, moving on to the clinical evaluation of the smile. The first is the lip aesthetics. Aesthetic evaluation of the lips is the important part of the diagnostic process and is the starting point for the clinical evaluation of the smile. The acronym LAMPP may be used to assess the lines, activity, as known as the function, and morphology, as known as the height and form, and posture and prominence of the lips. Lip line. The lip line represents the vertical position of the upper and lower lip in relation to the anterior dentition. The ideal dentolabial relationship results when the upper lip covers approximately the upper 2/3 of the maxillary incisor crown at rest with 2 to 4 mm maxillary incisor exposure. Women tend to have significantly greater maxillary incisor exposure than men. The interlabial separation is no more than 2 to 3 meters. The upper and lower lips are brought into contact with little or no circumoral contraction, with the lower lip covering the incisor third of the maxillary central incisors. The upper and lower lip lines must be evaluated with the patient in repose, in other words, the resting lip lines, and in the dynamic state of the speech and smiling. The resting upper lip line may be defined as the vertical relationship between the inferior border of the upper lip and the incisor edge of the maxillary incisor teeth. The ideal resting upper lip lines is with the upper lip covering the upper 2/3 of the maxillary incisor crown at rest with 2 to 4 mm maxillary incisor exposure. A high resting upper lip lines, which is sometimes termed as the high lip lines, lead to exposure of the entire clinical crown and associate gingiva of the maxillary incisor teeth, leading to excessive incisor exposure and sometimes associated gummy appearance at rest. A low resting upper lip line, which is sometimes termed as the low lip line, lead to exposure of the less than 2 mm of the maxillary incisor crowns. The maxillary incisor display may be non-existent at rest and in extreme cases in speech and in smiling. The no-tooth smile. There is a gradual reduction in maxillary incisor exposure in repose with advancing age. This is often accompanied by an increase in mandibular incisor exposure both in repose and in animation, such as speech and smiling. Vig and Brundo have provided normative mean value for incisor exposure in repose for Caucasian adults related to age. The resting lower lip line may be defined as the vertical relationship between the superior border of the lower lip and the incisor edge of the maxillary incisor teeth. The lower lip should cover the incisor third of the maxillary central incisor. In the animated state of smiling, the upper lip line should elevate to such a degree that the inferior upper lip border reaches the maxillary incisor gingival margin, displaying the entire incisor crown and interdental papilla and up to 1 to 2 of gingiva. Anecdotally, gingival exposure up to 2 mm in smiling is more attractive in women than men. The resting and dynamic lip lines are also correlated with the type of malocclusion with which a patient may present. For example, mandibular incisor exposure may be increased in class 3 malocclusion. Conversely, maxillary incisor exposure is often increased in class 2 malocclusion, particularly if the maxillary incisor is excessively proclined. The next topic is the upper lip maxillary incisor relationship. Leonardo da Vinci described the importance of the strongly movable section of the face around the mouth and chin in determining facial expression, emphasizing the importance of observing the face in animation as well as in the static state. One of the most important facial aesthetic parameters is the degree of exposure of the maxillary incisor teeth in relation to the upper lip, both at rest and in animation, in other words, in speech and smiling. The vertical exposure of the maxillary incisor in relation to the upper lip at rest should be 2 to 4 mm, and on smiling, the entire crown of the maxillary incisor should be exposed with up to 1 to 2 mm of associated gingiva. A spontaneous smile, which is involuntary and expresses joyous emotion, tends to raise the upper lip slightly more than a opposed smile, which is voluntary. The lip incisor relationship depends on the number of factors. Number 1. Upper lip height. Increased upper lip height will tend to reduce maxillary incisor exposure and vice versa. Upper lip height measured from subnasal to stomion superius is approximately 22 plus minus 2 mm in adult males and 20 plus minus 2 mm in adult female. Mid-filter height is roughly equal to or 1 to 2 mm less than a commissure height. This is measured from the oral commissure to horizontal line through a subnasal. Reduced mid-filter height results in an unattractive inverted arc appearance of the upper lip. Surgical procedures to increase the upper lip height may be required in such cases. It is important to take into consideration the increase in the upper lip height that occurs in adolescent patients with continued growth, particularly when treatment planning individuals with a shorter upper lip relative to commissure height. The upper lip height increases by approximately 3 mm between the ages of 10 and 20 years in male and female individuals. Intrusion of the maxillary incisors in adolescent patients may lead to an inadequate incisor display in later years. Number 2. Smile curtain. The smile curtain may be defined as the muscular capacity to elevate the upper lip. The elevation of the upper lip from repose to full smile exhibits considerable individuals' variability, averaging 7 to 8 mm, with the range of the 2 to 12 mm. If the position of the maxilla and maxillary incisor in relation to the face is correct, yet the patient presents with a gummy smile due to the vertical hypermobility of the upper lip, the option of the botulinum toxin type A injection to the levator muscle of the upper lip is available. Alternatively, surgery to reduce the mobilization and the elevation of the upper lip may be undertaken using techniques originally described by the Kostianowski and Rubinstein, later described by the Kammer. Number 3. Vertical position of the anterior maxilla and incisor teeth. The more inferior the position of the anterior maxilla, the greater exposure of the maxillary incisor and vice versa. Vertical maxillary excess, which is commonly briefed as the VME, may result from excessive inferior development of the maxilla. This is often accompanied by the excessive gingival display at rest and on smiling, sometimes referred to as a gummy smile. Treatment, therefore, centers on superior repositioning of the maxilla. In certain cases, anterior VME may be due to excessive over-erupted maxillary incisor, for example, the Class II Division II metaocclusion, in which case the treatment of choice will either be an anterior segmental impaction of maxilla or orthodontic intrusion of maxillary incisors and associated gingiva. Number 4. Sagittal position of the anterior maxilla and incisor teeth. The more anterior the position of the maxillary incisors, the greater the exposure of the maxillary incisors and vice versa. The increase in incisor exposure that occurs with maxillary advancement or reduction in incisor exposure with maxillary setback, surgery must be taken into consideration. Concomitant maxillary impaction or inferior repositioning may be required in order to obtain an adequate upper lip incisor relationship. Number 5. Inclination of the maxillary incisor teeth. Retroclination of the proclined maxillary incisors toward the correct inclination increases the incisor exposure as the teeth rotate around their center of resistance. Maxillary incisor crown inclination may be ideally evaluated on a profile smiling view. Number 6. Maxillary incisor crown height, including the presence of the incisor wear. Short maxillary incisor crown and vertical wear of the incisor crowns reduces the incisor exposure. Average maxillary central incisor crown height is approximately 10 mm. Number 7. Vertical level of the gingival margins on the labial surface of the maxillary incisor crowns. It is important to note that the gingival margins of the maxillary incisors may migrate gingivally until late adolescence, which is described as the delayed apical migration of the gingival margin, reducing the gingival exposure and exposing the normal crown height. In adolescent patients with excessive gingival exposure, the gingival circular depth may be assessed with a periodontal probe. Normal midfacial circular depth is around 1 mm, with the cemento-enamel junction located at depths of the sulcus. If the circular depth is found to be significantly greater than 1 mm in the absence of gingival inflammation, it may take a number of years for the gingival margins to migrate to the normal relationships. That is, the diagnosis is a delayed apical migration. In such cases, gingivectomy may be required. Gingivectomy or crown lengthening procedures may also be required in adults with short clinical crowns and excessive gingival display. Treatment planning for the correction of the deep incisor overbite or excessive vertical overlap of the maxillary and mandibular incisor teeth requires accurate preoperative diagnosis. If the lower anterior facial height is correct, the etiology of the deep overbite will be dentoalveolar. In such cases, extrusion of molar teeth to reduce the overbite is best avoided, as this would increase the lower anterior facial height. Intrusion of maxillary incisor teeth must be undertaken sparingly and bearing in mind that in adolescent patients, the upper lip height will increase with growth overall, leading to reduced maxillary incisor exposure and an aged appearance to the smile. Therefore, in a large number of patients, it is preferable to actively intrude the mandibular rather than the maxillary incisors. As always, accurate diagnosis is essential for correct treatment planning. Moving on to the incisor exposure and phonetic analysis. The position of the maxillary central incisors in relation to the upper lip is a key to smile aesthetics. All other teeth are positioned relative to the maxillary central incisors. Phonetic analysis may be employed to help determine the position and degree of exposure of the maxillary incisors in relation to the lips. F and V sound. These sounds are produced when the incisor edges of the maxillary incisors and canine make light, momentary contact with the wet-dry line of the lower lip. Phonetic analysis permits evaluation of the ideal vertical level of the maxillary incisor edges. In other words, maxillary incisor edges should not be positioned or restored more inferiorly than this parameter. E sound. Prolonged pronunciation of the E sound creates an interlabial gap which is occupied to a variable extent by the maxillary incisor teeth. In younger patients, the interlabial gap should be occupied almost entirely by the maxillary incisor teeth, whereas in elderly individuals, this gap will be partially occupied by the maxillary incisors. This parameter is helpful in determining the vertical level of the maxillary incisor edges. The next is the M sound. The prolonged M sound helps to place the patient in the mandibular rest position with an interocclusal freeway space of 1 to 3 mm. It also helps to place the labial musculature in repose. This helps the prosthodontist determine the occlusal vertical dimension, which will be between 1 mm and 3 mm less than this rest position, and permits the orthodontist and surgeon to evaluate maxillary incisor exposure in relation to the upper lip with the soft tissue in repose. S sound. creation of S sound is described as the S position requires a space of the 1 to 1.5 mm between the maxillary and mandibular incisor teeth, permitting air to be forced between the mandibular incisor edges and the palatal surfaces of the maxillary incisor teeth. Alternatively, some patients protrude the mandible into edge-to-edge incisor relationship, albeit with the same spaces. That is, the teeth do not make contact during enunciation of the S sounds. The S position may be used to determine the anterior occlusal vertical dimension, which will be approximately 1.5 mm closed from the S position to achieve occlusal contact. The correct position and thickness of the palatal surface of the maxillary incisors and the labial surface of the mandibular incisor may also be determined by the S sounds. It is important to always use and compare the result phonetic analysis with the results of the comprehensive dentofacial and smile analysis. One methodical and thorough clinical evaluation will permit correct diagnosis. Regarding the phonetic analysis and aging, the maxillary incisors exhibit greater exposure on smiling, whereas the mandibular incisors tend to exhibit greater display during normal speech. Patients usually examine their smile in a mirror and are often too unaware of the degree of mandibular incisor exposure in normal speech. It is not uncommon for patients to claim that they only want straight top teeth, as the lower teeth do not really show. The degree of mandibular incisor exposure during normal speech becomes even more pronounced with advancing age as a result of sagging of the circummolar soft tissue. It is important for clinicians to educate their patients regarding this phenomenon during the treatment planning phase. When planning to restore the height of maxillary incisors, three parameters must be evaluated. The first one is the aesthetics. The aesthetic parameter is the exposure of the maxillary incisor in relation to the upper lip with the patientary pose. Anterior occlusal guidance. Anterior occlusal guidance is also termed as the incisor guidance, may be examined by asking the patient to protrude the mandible while observing the dental occlusion. The incisor edge of the mandibular incisor slide down the palatal surface of the maxillary incisors, simultaneously resulting in disclusion, that is, the separation of the posterior dentition. Maxillary incisor restoration may fail as a result of the unwanted protrusive occlusal interferences if the incisor guidance is sacrificed at the expense of aesthetics. Phonetics. Phonetic analysis will permit the restoration of such height that phonetics are not compromised. The next topic is the smile symmetry. In this context, the smile symmetry refers to the bilateral symmetry of the smile frame during animation. In other words, the relative vertical position of the oral commissure in smiling. There may be a difference in the extent of elevation of the left and right halves of the upper lip and oral commissures in smiling. A minor difference is acceptable and may be even deemed attractive. Elvis Presley's famous smile is the classic example. However, excessive differential elevation of the left and right side of the upper lip may result from reduced unilateral muscular tone. It is notable that an asymmetrical smile and obliquity of the intercommercial plane may lead to a misdiagnosis of transverse cant of the maxillary occlusal plane. The upper lip curvature refers to the curvature of the upper lip formed in the animated state of smiling as observed in the frontal view. It is evaluated as the curvature from the middle of the vermilion of the upper lip to the lateral commissures. It is mainly directed by an individual's muscular anatomy involved in the development of smile, but also may depend on the dentoskeletal morphology. For example, if severe bimaxillary dentoalveolar protrusion is corrected, it is likely that the upper lip curvature when smiling may alter. The upper lip curvature is described as straight when the lateral commissures and the central vermilion of the upper lip are at the same vertical level on smiling. Upward if the commissures are higher than the central vermilion, and downward when the commissures are lower than the central vermilion. Straight and upward lip curvatures are deemed more attractive. In a normal Caucasian population, the prevalence of straight and downward upper lip curvatures were found to be approximately equal, more strictly 45% to 43% respectively, whereas the upward lip curvature was less than common. The presence of transverse cant of the maxillary occlusal plane is an important factor in the evaluation of the anterior smile aesthetic. A true transverse cant may be of skeletal or dentoalveolar etiology. The clinical result is rotation of the maxillary occlusal plane around the sagittal axis. It is important to bear in mind that an apparent transverse cant may result from soft tissue smile asymmetry. That is, there is no transverse cant, but the asymmetrical smile gives the visual impression of the maxillary cant. The presence of unnatural sagittal cant of the maxillary occlusal plane may have detrimental consequences on smile aesthetics. Poor aesthetics may result if the posterior plane of occlusion is established too high, for example, from excessive posterior impaction of maxilla, or too low, for example, from posterior vertical maxillary excess, due to excessive downward vertical growth of the posterior maxillary dentoalveolus. In patients with posterior vertical maxillary excess, the posterior teeth may be observed to hang down below the plane of the maxillary incisor on smiling, which is detrimental to smile aesthetics. For ideal aesthetics, the sagittal maxillary occlusal plane from the anterior maxillary incisor edge to the posterior molar cusp tips should be approximately parallel to the campus plane, which is also termed as a ala tragal or nasotragal line, which runs from the middle of the tragus of the ear to the nasal ala base. Campus plane, commonly used in the construction of the complete prosthetic dentures, is said to make an angle of approximately 8 degrees with front-foot horizontal plane or true horizontal plane. Intraorally, the sagittal maxillary occlusal plane should extend posteriorly to a point midway up the mandibular retromolar pad. The smile curvature, alternatively termed the smile arc or smile line, may be defined as the relationship of the curvature of the incisor edge of the maxillary anterior dentition to the curvature of the upper border contour of the lower lip. In a paused smile, the incisor edge curvature is a hypothetical curve drawn along the incisor edge of the maxillary anterior teeth. The importance of this concept was proposed by the John Frush and Ronald Fisher in the dental prosthetic literature. In an ideal smile, the incisor edge curvature runs parallel to the lower lip curvature. The incisor edges should be just at the border of the lower lip, though there may be a slight separation. The appearance is acceptable if the lower lip just but not excessively covers the incisor edges. If the incisor edge curvature is flat or reverse relative to the lower lip curvature, or if the lower lip contour is abnormal, the smile may be unattractive. Moving on to the next part, the dental midline will be discussed. The relationship of the dental midlines to their respective jaws and to the facial midline must be evaluated. First, we will talk about the maxillary dental midline. This may be assessed in relation to the midpoint of the upper lip, the cupid bow. In addition to the relationship of the maxillary incisor to the facial midline, their transverse angulation must also be assessed, as increased transverse crown angulation in frontal view is detrimental to dentofacial aesthetics. The next is a mandibular dental midline. This is assessed in relation to the facial midline, maxillary dental midline, and midpoint of the chin. Although an incorrectly placed mandibular dental midline is unlikely to adversely affect the smile aesthetics, it is important to have coincident midlines to produce a well intercuspated dental occlusal. The next topic is the buccal corridors, which is also known as the negative space. The buccal corridor or negative space is the space revealed between the buccal surface of the posterior teeth and the commissures of the lip when a patient smiles. The presence of dark buccal corridors, excessive lateral negative space may be due to, first, transverse narrowing of the maxilla, especially in the premolar region. When excessive narrow expansion of the maxillary arch may be required in order to improve the arch form and dental occlusion, an additional advantage is that such expansion helps to fill the corner of the smile. Second, palatal inclination of the maxillary posterior dentition. The terminal tooth exposed in smiling is often the first or second premolar. As such, it is important that maxillary premolar crowns are not palatally inclined. When this is the case, increased buccal crown inclination and expansion of the posterior maxillary dentition, primarily in the premolar region, are required. In aesthetic dentistry, an increase in the thickness of the buccal aspect of ceramic restoration on the premolar teeth may help to fill out the smile. Third, retropositioned maxilla. Maxillary advancement is the treatment of choice, as having the maxilla anteriorly permits a wide part of the dental arch to move forward and reduce the lateral negative space. Fourth and last, dynamic intercommercial distance. Normal values for intercommercial distance, as known as the mouth width in repose, have been provided by Farkas. In male, 55 plus minus 3 mm, and in female, 50 plus minus 3 mm. Data on changes in mouth widths in the dynamic state of the smiling are limited. However, Rigsby and colleagues demonstrated that in an attractive smile, the mouth increased to 130% of its original width. There is likely to be considerable individual variation in the degree of increase in intercommercial distance in smiling. The greater this increase, the greater the potential for lateral negative space in smiling. Additionally, the vertical dimension may be the cause of buccal corridors. It has been demonstrated that an increased lower anterior facial height, which is measured from the subnasal to soft tissue menton, and in particular the lower lip chin height measured from the stomion to the soft tissue menton, are negatively correlated with the buccal corridor area. In other words, the two-dimensional area visible in the frontal view. This is thought to be due to an increased stretch of the lower facial soft tissue in patients with increased lower facial height, and thereby reduce the buccal corridors in smiling. Now we are talking about the smile aesthetics in profile view. The relationship of the maxillary incisors with respect to the facial profile is one of the cornerstones of the facial aesthetic treatment planning. This relationship depends on the sagittal and vertical position of the maxillary central incisors in relation to the face, and importantly, on the inclination of the labial face of the maxillary central incisor teeth. The inclination of the maxillary incisors is important both in terms of occlusal function and dentofacial aesthetics. Excessive proclination of the maxillary incisors is unattractive and reduces incisor exposure in repose and in animation. It may also lead to a traumatic occlusion as a result of injury to the maxillary incisor periodontium from occlusal loading in non-physiological direction. In other words, mandibular incisor striking the maxillary incisor at an incorrect angle, thereby not permitting the normal dissipation of occlusal forces. Excessive retroclination of the maxillary incisor is also unattractive, though incisor exposure may increase as a result of over-eruption of the maxillary labial segment. Fredericks described the treatment objective of achieving a labial crown face inclination parallel to the facial plane, that is, Nasion to Paganian. However, the anatomic facial plane is subject to individual variability. Therefore, maxillary incisor crown inclination is ideally evaluated in a facial profile smiling view and on lateral cephalometric radiographs with a patient in natural head position. A tangent to the labial face of the maxillary central incisor should be parallel to the true facial vertical plane. It is important to distinguish between maxillary incisor protrusion and proclination. Patients may present with maxillary dentoalveolar protrusion, proclination, or a combination. Protrusion signifies an excessively forward sagittal position of the anterior dentoalveolus, whereas the proclination signifies excessive forward inclination of the incisor teeth. Correction of maxillary incisor protrusion thereby requires bodily retraction, whereas the proclination requires retroclination, which means the rotation around the center of the resistance to the correct inclination. Regarding buccal corridors, I would like to add the concept of the concealed premolar smile. A great deal of attractiveness research has been carried out on the influence of buccal corridors on the perception of smile attractiveness. Orthodontists generally do not like buccal corridors, yet the result of research indicate that the lay people do not share this orthodontist dislike. In denture prosthetics, a degree of lateral negative space is planned and thought to give a more natural appearance. Overall, it is likely that the parameter leading to the perception of smile attractiveness is not the presence or absence of buccal corridors, but the visibility of the posterior dentition distal to the maxillary canine teeth. In patients with adequate visibility of the premolar teeth when observed in frontal view, the presence of buccal corridors is unlikely to be perceived as unattractive. Conversely, in patients with a narrow canine-to-canine smile, with the premolars concealed behind the canine teeth, that is the concealed premolar smile, the smile attractiveness is likely to be unsatisfactory. Okay, this is the end of today's and this semester's lecture. But we continuously discuss about the further and remaining topics of the facial beauty. If you would like to participate in this journey, please join via YouTube channel. Tentatively, we have a plan to write several review papers on facial beauty. Keep in touch. It's my great pleasure to have you in this class.